Good morning everyone. I am Dr. Sushruth, MBBS MS General Surgery, and today we'll look into the appendix. So the appendix is a 8 to 9 centimeter long appendage, usually present in the retrocecal in about 75% of the individuals and about 21% present in the pelvic region. On an average, it's 8 to 9 centimeters, but may vary from 5 to 35 centimeters and may have other less frequent locations like the pre-ileal, the post-ileal, and all of these locations have certain presentations which we'll see. So the appendix gets its blood supply from the superior mesenteric artery, which gives a branch called the ileocholic, which gives the branch of the appendicular artery. The appendicular artery runs in the mesoappendix along with the lymphatic channels, which empty into the ileocecal lymph nodes. There is also an accessory appendicular artery known as the artery of Sesachallam, which comes from the posterior cecal artery. This accessory artery is present in as many as 50% of the individuals. Coming to the histology of the organ, it has a colonic type mucosa with the columnar epithelium with neuroendocrine cells and goblet cells. The submucosa contains lymphoid tissue, suggesting that the appendix may have some role in the immune system. The appendix is also a reservoir of good intestinal bacteria, thus maintaining the normal intestinal flora. Whenever we are removing a grossly normal appendix at the time of an unrelated procedure, it's called an incidental appendectomy, and the recent data suggests that both the morbidity and mortality increases when we are doing so. So we do not advocate the use of incidental appendectomy unless an abnormality is detected or an indication is present. Coming to appendicitis, so it's a disease of the younger age, peaking in the teenage years. It's usually associated with a polymicrobial infection, and the antibiotics should cover both the gram negatives and the anaerobes. The common isolates are E. coli, Pseudomonas, Klebsiella, and the bacteroids. Pathophysiology of the appendicitis follows a luminal obstruction, which is most commonly caused by feculates, ascaris, food particles, foreign bodies, neoplasias, lymphoid hyperplasias like the Peyer's patches. This leads to a continuous mucus secretion and the inflammatory exudate, which increase the intraluminal pressure. The initial visceral pain is usually referred to the umbilicus, as the appendix is part of the midgut, and the midgut shares a dermatomal supply with the umbilicus, which is T10. The typical right lower quadrant pain develops when the tip of the appendix gets inflamed and it irritates the parietal peritoneum, thus causing a migration of pain from the umbilicus to the right lower quadrant. Now this leads to obstruction of the lymphatic drainage, leads to edematous walls, mucosal ulceration, bacterial translocation, venous obstruction, and ischemia, and finally leading to a perforation, most commonly at the tip. Now this perforation is more commonly seen in patients who have diabetes associated with feculith and present in extremes of ages, pelvic appendix, and previously operated abdomen. The greater momentum, the small bowel can become adhered to the inflamed appendix, leading to a limitation of the peritoneal contamination, thus resulting in an abscess or a phlegmon. Free bacterial contamination of the peritoneal cavity can lead to diffuse peritonitis. So presentations can be varied depending upon how immunocompromised or immunocompetent our patient is. Rarely, the inflammation may resolve, leaving a mucus-filled organ termed as the mucocele of the appendix, as shown in the figure. The CT also shows multiple radiopaque appendicolits. Now, at the clinical presentation, the patient should first be evaluated whenever they present with a suspicion of appendicitis using the modified Alvarado score. because it has a high negative predictive value and it is very useful to rule out appendicitis. So it's divided into the symptoms, the signs, and the laboratory. The symptoms contain migration, anorexia, nausea. The signs include tenderness in the right lower quadrant, rebound tenderness, and elevation of temperature. Laboratories include leukocytosis and a left-sided shift, which is increase in the neutrophilia, and a left-sided shift, and a total score of 10 is given, and the predictability is as shown. If it's less than 4, 5 to 6, 7 to 8, and 9 to 10, the likelihood increases of it being appendicitis as our final diagnosis. There are multiple other scores, but this is the simplest one and can be done bedside with the preliminary laboratory reports. Other scores include the Zanicki score, the pediatric appendicitis scores. There are multiple signs that can be illustrated if we look at the classical teaching. It's obviously the tenderness at the Meperny's point, at the line joining the anterior superior iliac spine and the umbilicus, about 1/3 from the anterior superior iliac spine. There's also the pointing sign where the patient points towards a worsening pain and the viscerosomatic migration of pain, usually at the right lower quadrant. There's the Rovsing sign wherein you press the left lower quadrant and the patient elicits a pain in the right, and you can elicit the pain in the right lower quadrant. There's a psoas sign where if you ask the patient to hyperextend the hip joint, the patient may wince with pain. And then there's the obturator sign where if you internally rotate the knee while taking the ankle laterally, the patient may have increased pain. There are also the non-specific signs, the Dunphy sign, the Aaron sign, and the Tenhorn sign, which are pain when the intra-abdominal pressure increases, like when the patient is coughing, and pain pain which can be localized to the peri-umbilical region, and whenever the right lower quadrant is pressed, and pain whenever the spermatic cord is put under tension. Now there are multiple presentations depending upon the location of the appendix theoretically. In case of a retrocecal appendix, it's most likely a silent appendix with the psoas sign being positive. The pelvic appendix, which may irritate the bladder, which leads to an increased urinary frequency. It may irritate the rectum and cause a pelvic diarrhea along with tenesmus, and increased pain on digital rectal examination is also seen. So the lab tests include total leukocyte count, a differential count, and inflammatory markers. Imaging tests are done to reduce negative appendectomy rates. Plain radiograph may show calcified fecaliths in the right lower quadrant. Pneumoperitoneum is a very rare finding because the tip of the appendix has less than 10 ml of air, and pneumoperitoneum may not be stated in such. A CT scan is now become the most common study to diagnose appendicitis. Sensitivity and specificity tend as high as to 100%, and a thickened appendix of more than 7 mm with the surrounding fat stranding may be suggestive of appendicitis. Cases in which appendix is not visualized or the absence of the inflammatory findings are seen on CT usually suggest that the patient does not have appendicitis. Now coming to ultrasound, a graded compression ultrasound used to collapse the surroundings and bowel to diminish the interference is used. An inflamed appendix is usually enlarged, immobile, and incompressible, along with the elicitation of probe tenderness. A blind ending tubular structure is usually seen, and fecalith may be present. If the appendix is not visualized, the study is said to be inconclusive. MR has a role reserved for pregnant women, and it is usually performed without contrast. Coming to the differential diagnosis, which we should always keep in mind for infants and children, mesenteric adenitis, secondary usually to a Yersinia infection, may classically mimic presentation of appendicitis, along with which intussusception, Meckel's diverticulitis, and gastroenteritis and UTI should always be kept in the back of the mind. For adults, adult males, testicular torsion along with UTI and gastroenteritis should also always be ruled out. And for females, Mittelschmerz and PID along with endometriosis should be kept in mind. An ectopic pregnancy is always an important differential and should be ruled out. For elderly, diverticulitis becomes a very common diagnosis. A colonic malignancy should always be ruled out in the elderly. For immunocompromised patients presenting with appendicitis, prompt appendectomy should be done. So early CT is advisable for them. So coming to the treatment of appendicitis, the incisions given for open appendectomy are shown in the figure. There's the McBurney's incision, which is perpendicular to the line joining the ASIS and the umbilicus, usually 1/3 distance away from the ASIS at the McBurney's point, perpendicular to the line. We may further continue the incision as a muscle splitting one, which is the Gridiron's incision, or the muscle cutting one, which is the Rutherford-Morris incision. There is also the transverse incision, which is called the Rocky-Davids incision, which can be medially extended to a Fowler-Weir extension or a laterally extended incision, which is the Rutherford-Morris extension. There is also the Bickney incision or the Lanz incision, which is along the skin crease, thus known the Langer-Lynes incision too. In cases of diffuse peritonitis, a lower midline incision should be given wherever you're suspecting perforation of the appendix. So coming to the debate of lap versus open, the overall conclusion of a number of trials says that laparoscopic approach is associated with a lower incidence of complications. Advantages include lower overall morbidity, reduced wound complications, reduced post-operative pain, shorter recovery time, and it allows the examination of the entire peritoneal space to exclude any other abdominal pathologies. Previously, the classical teaching told us that the disadvantages include a higher risk of post-operative abscess formation in cases of complicated appendicitis, but newer trials, even the Jerusalem trial of WSES, tells us that actually not much difference in the formation of post-operative abscess between the two techniques. General approach to patients with suspected appendicitis. Clinically, appendicitis is suspected and the patient presents early, that is within 48 hours. The patient presents with a classical presentation of localized peritonitis. Go forward with a laparoscopic appendectomy. For equivocal presentations, CT should be done and early CT should be done. If appendicitis is present, laparoscopic appendectomy should be done. If the CT shows no other pathology and appendicitis could not be ruled out, a brief period of observation can be done, and if the patient is improving, we can discharge them for follow further. If the patient is not improving, the patient should be taken for a diagnostic laparoscopy. The gold standard treatment in uncomplicated appendicitis is prompt appendectomy. The patient should be started on IV fluid resuscitation, antibiotics, and analgesia, and proceeded with laparoscopic appendectomy. Antibiotic administration is not continued usually beyond a single preoperative dose. Oral feeds are started immediately and advanced as tolerated. So patients with a delayed presentation of suspected appendicitis, we should first rule out a diffuse peritonitis picture. If the patients are having a diffuse peritonitis, they should be resuscitated, started on antibiotics, and finally taken to the OT for source control. If they're not having such a presentation, they should undergo a CT. There's no perforation. If there is no perforation, the lump is present, a conservative management should be followed. If there is perforation and abscess has formed, a CT guided or an image guided drainage should be done. If it's not feasible, a laparoscopic drainage and antibiotics should be started. The patient is an adult that is more than 40 years of age. The patient should go colonoscopy after their discharge. If it's normal, the patient should undergo interval appendectomy. So immediate exploration may result in substantial morbidity and failure to identify appendix, post-operative abscess, or formation of fistula in cases of delayed presentation. In case of a perforated appendix, Both laparoscopy and open are acceptable approaches for the patient. After appendectomy, clearance of infectious material using a large volume of irrigation and suction should be done, and drains are not routinely recommended unless a discrete abscess cavity is present. If open technique is used, the skin and subcutaneous tissue should be left open for at least 2 days, and delayed closure is done. Post-operative antibiotics are usually continued for 4 to 7 days, and oral feeds are usually started after the return of bowel sounds and passage of flatus. If the patient develops fever, leukocytosis, pain, and delay in return of bowel function, a post-operative abscess should be suspected and confirmed using imaging, usually an ultrasound or CT, and drained by a percutaneous drainage. So, an interval appendectomy should be considered based on the potential of developing recurrent appendicitis or reperforation of the appendix. However, the risk of recurrent appendicitis is low, and based on a number of trials, the patient can be followed up, and interval appendectomy may be reserved for a number of patients who present with symptoms of recurrent appendicitis. The presence of appendical litho is a predictor of high risk of appendicitis, and interval appendectomy is indicated with patients with the presence of an appendical lith. Another argument favoring the interval appendectomy in adults is that a high incidence of appendiceal neoplasms are found in interval appendectomy, especially in patients of more than 40 years of age, and thus a colonoscopy is recommended in all adult patients after non-operative management of complicated appendicitis, as perforated tumors of the cecum may manifest in a similar fashion. For pregnant patients presenting with suspected appendicitis, such patients should undergo ultrasonography, and if appendicitis is confirmed, they should undergo an appendectomy. If ultrasound shows no such findings, an MR can be considered in cases of high clinical suspicion. The MR is suggestive of appendicitis, they should undergo appendectomy. So, appendicitis still remains the most common non obstetric emergency in pregnant patients. The pain of appendicitis in pregnant patients is felt slightly above the McBurney's point as the uterus pushes the appendix upwards. Lower quadrant pain can also be produced by traction on the sensory ligament known as the round ligament pain. Febrile response to illness is blunted in pregnancy, and leukocytosis and raised CRP may also be physiologically present in pregnancy. A complicated appendicitis is associated with increased risk of preterm labor and fetal losses. However, negative appendicectomy is also associated with increased risk of preterm labor and fetal loss. Appendectomy is a safe procedure in all trimesters, and both the lap and the open techniques can be used. If ultrasound is inconclusive, MR is not available, CT scan should be done as the amount of radiation delivered during a limited CT is below the threshold required to induce fetal malformations, and that most cases occur in about second to third trimester where organogenesis is already completed. So, what should we do in cases where a normal appearing appendix is present at the time of surgery in patients suspecting appendicitis? First, a terminal 60 centimeters of the ileum should be examined for Meckel's diverticulum, and the serosa of the small bowel is looked for inflammation, stricture formation, and creeping fat mesentery to rule out a Crohn's disease. Adnexa should be examined for evidence of any tubo-ovarian diseases. Acute diverticulitis in cases where redundant sigmoid colon is found in the right lower quadrant may also produce symptoms mimicking appendicitis. We should routinely remove normal appendix in such a case because it will remove appendicitis in differential diagnosis when patient presents with a recurrent right lower quadrant pain. Appendicectomy is also advised in cases where Crohn's disease is suggested by findings at operation, unless the base of the appendix and the cecum are involved, due to a higher risk of postoperative fistula formation in such cases. So post-appendectomy complications, the most common complication is wound infection. Again, there are complications like intra-abdominal abscess, post-operative ileus. A rarer complication is pylophlebitis, which is portal pyemia, associated with fever, jaundice, multiple intrahepatic abscess. The treatment is antibiotics and percutaneous drainage. And the most common late complication is adhesive intestinal obstruction. Thank you.